places. It's a pleasure for me to lecture to you tonight about, or tomorrow, in this morning. I don't know where you are listening to my lecture, or maybe it's even during the day, to a very interesting concept in periodontology. For me, it is always very frustrating seeing patients in a situation as it is presented here. And we are very much concerned not only about the periodontal diseases, but also diseases which are resulting out of these parts and which could affect the whole body. But before we are going now into the concept itself, I think it is always important to see and to focus on the part which might be the major reason for this kind of diseases, and to find out what way we could go in order to approach this kind of problem in a way to avoid maybe some kind of treatments which could affect the whole body in a negative way. For this reason, I just want to draw your attention to the AAP statement, which was published in the Journal of Periodontology in July 2007, American Academy for Periodontology. And I don't want to read now every sentence to you, as you can see it and can read it by yourself. I think the most important thing is that we are confronted with a major colonization of different types of bacteria, mainly gram-negative bacteria. And so for this reason, I think our attention is drawn to the problem, to the reason of the problem, and to see in which way we can solve this kind of problem. For other reasons, we have to think and to understand that we are not only confronted with one specific type of pathogen bacteria, but of a differentiation of different types of bacteria. And of course, if we want to treat a patient and his disease in the right way, we have to know that not only the mechanical therapy is the most accessible or the most successful part, but also we are very often confronted with a problem to use antibiotics, and of course in a way that we can reach all these different type of spaces in a way to really regenerate and heal the periodontal diseases. Now, again, a little illustration done by the American Academy for Periodontology, which should illustrate you once more my statement where actually the origin of the disease is. I don't want to give you now a basic lecture on periodontology, but as we want to integrate the laser technology in this problem, or in solving this type of problems, we have to understand where the reasons are and how we can approach them. And that means also here, when we can see this part here, I would like to draw your attention to the parts where we can look into seeing here the bacteria in the plaque or in the biofilm. And of course, this is going to affect, first of all, the gums. We see the signs of inflammation. When this is going to progress, new bacteria are settled. We see already the reducing bone due to the inflammatory response to bacteria. And that is for all of us a clear sign that a very negative happening is taking place. And this is going on. Pockets are formed, and we have a decreased bone loss, which actually will lead us to more severe problems in periodontology. Then the next part is coming. We have an increase of plaque and bacteria due to the bigger exposure of surface, of root surface. And again, this vicious circle is starting. So in order now to go and find the right way of treatment, for me and for the concept which I will explain later on to you, is that when taking a diagnosis, one of the most important things for me is a microbiological test, because only with this type of microbiological test we have the possibility to examine what types of bacteria are found and in which quantity they are found in the periodontal pocket and in the surrounding tissue. Now, knowing the types of bacteria and the amount of them, we also can come much easier and closer to a very detailed diagnosis, which later on will also help us to discuss with our patient the prognosis of the disease and also in which way and when to integrate the laser in our periodontal treatment concept, or even maybe that we say, okay, this type of periodontal disease is not that much severe so that we would need an additional treatment by a laser. When finding this, of course, looking at the different types of diseases, we know today the aggressive periodontitis or chronic periodontitis are showing very clear signs, but just looking at them and seeing some inflammation, some plaque formation, then of course also the bleeding on probing, or going to another more severe disease like the necrotizing ulcerative periodontitis. Maybe sometimes we think, oh, it's not that much severe. We see it maybe in a more detailed form when it's more aggressive. Then, of course, we are more concerned about our treatment and how we could approach it. But also in areas where normally we are not so often confronted with gingivitis, in pregnancy, for example. But as you can see here, one patient of mine, 30-year-old patient, in the 8th month before pregnancy, already medium severe gingivitis. All these cases should draw our attention not only to the periodontal disease, but the overall happenings. Now, in order to show you why I'm giving you this introduction, why it is so important for me to explain those things to you, is because we have a very interesting development in our society, not only here in Germany. If you go in the internet and you will try to find out the different oral health studies in other countries, in the United States or in other parts of Europe, in Asia, then you will find out that periodontal diseases are increasing. Now, because I'm from Germany and so I don't want to discuss other oral health studies, but if you see this index which I'm presenting here to you, then you can see that within our society in Germany, we are finding a situation that already a big number of patients are suffering under less but also more severe periodontitis. As you can see here, the graph in the left side, these are the teenager group, 15 years old, and you can see already more than 12% showing less severe periodontitis. In the bigger group of our society, the strong working group, persons between 35 and 44 years, you can see 50%, 50, are suffering under less severe periodontitis, but already 20% under a severe periodontitis. So we can say approximately 70% of this group of patients are having periodontal diseases. And then if you go to the old age group in our society, the pensioner group, 65 to 74 years, you might say almost every person is suffering under a certain type of periodontal disease, more or less severe. That is somehow a bit frightening to us, especially if we are looking on this graph, which I would like to show to you, to sensitize you to the problem. Because as you can see it here now, in the year 1997, we had in this major working group an approximal 32% less severe and about 15% severe periodontitis. Not even 10 years later, 2005, we are facing a situation where we have already more than 46% of less severe, but already about 20% severe periodontitis. And now we are wondering ourselves, if we are taking this in consideration statistically, then you can see periodontal diseases are increasing. Now we could ask ourselves, what might be the reason for this development? Are we having a less good health system, or is the explanation, the education within our society not good enough, so that people are not understanding really the need of good oral health and so on? Or is the information in our schools towards our children not so intensive anymore as maybe years before? No, we can't say that, because I think even the informations are better, and almost in every better or bigger TV program, when there are the announcements in different parts, we always find some parts where also dentistry and periodontal diseases are mentioned. So we cannot think that is a lack of information. There must be other reasons behind finding such a situation. So that means now we have to question ourselves, what might be a reason? And I'm saying what might be a reason, or what could be a reason. If we are looking in the classical statements of periodontal therapy, then whether it's the American Academy for Periodontology, whether it's the German Society for Periodontology, whether it's the European Society for Periodontology, or whatever, all of these big periodontal organizations, even the classical treatment concept in our university, in my department, is that beside the classical mechanical scaling and root planning therapy, we are advised, and we should take it very carefully in consideration, that an additional therapy with antibiotics should be done if, as you can see it here, primary periodontal bacteria are found, therapy-resistant periodontal bacteria are seen in during our treatment, and special forms of periodontitis are appearing. Now, thinking about now these three major statements, then I think especially those ones who want to go very much according to all these major guidelines will not take a decision against the use of antibiotics. And let me tell you very clearly, I'm not against the use of antibiotics. Number one, I just want to underline that so that we don't have a misunderstanding later. What I want to say is we have to think about what could be a reason of an increasing of periodontal diseases. On the other hand, what could be done in order to compensate, or yes, to compensate, I think is the right word in English, this type of therapy with another treatment which is more biological orientated but less aggressive towards the whole system, to all our body. And this is why I would like to point out once more, if you look at the major pathogenic bacteria, as you can see them listed up here, and the agent to destroy them, then we will find that we have to combine at least two different types of antibiotics, like it is highlighted here in yellow, metronidazole and amoxicillin, in order to have the best possible chance to destroy those pathogenic germs. That means for us, we are forced to find a way with quite a high doses over a long time, systemically given antibiotics to fight those aggressive bacteria within our periodontal pockets. But as we all know, this will also affect our whole body, our digestive system, and so on, and also the function of our immune system. Now, due to the fact that we are facing the problem, as I showed it to you before, that about, let me say, in an average, 60 to 80% of our population is suffering under periodontal diseases, we should really think what is going to happen if we continue treatments as we are doing them today in future. Now, for those ones who are more in research or who are qualified specialists in periodontology, they will be very much aware of the Journal of Clinical Periodontology. And for those ones who are more doing periodontology in private offices or as private practitioners, I would like to introduce this journal as a very well-known, highly accepted periodontal journal. The year 2006, an article was published in this journal, and I just wanted to highlight the aim of the study, which says effects of metronidazole plus amoxicillin is the only therapy. Just pay your attention to the highlighted only therapy in yellow, which I did, on the microbiological and clinical parameters of untreated chronic periodontitis. Now, pay attention. That means the study, or in this study, the aim was to see whether we can address those parts, microbiological and clinical parameters. Now, what was going on in this study? I just want to summarize it to you in order that you can understand it a little bit better. Look at this graph here out of this study, and you can see the reference. You can read it yourself for those ones who have access to this journal. Average bacteria profiles after 3, 6, 9, and 12 months after scaling and root planning, and therapy exclusively with metronidazole and amoxicillin. So in order to see what is happening here, you see on the left hand of this table, you see scaling and root planning only. And on the right side, you see met plus amox, so metronidazole plus amoxicillin. And also for those ones who have not been doing too much research, if you look on this table, you will easily find and say, well, this seems to be the same results. There is not a major or significant difference. And I have to say, this research was done was done with a lot of efforts, looking at the big number of different pathogenic bacteria on the left side listed down. So it was quite a very expensive study, and doing such an expensive study over a long term, like 12-month study, must have been quite expensive. But we are not only looking on the expensive side of the study, but seeing here that there is no significant difference, we want to see what was the conclusion out of the study. And looking at the conclusion, we are finding, oh, that is similar what we have found in the picture before. Conclusion, the effectiveness of metronidazole plus amoxicillin to reduce subgingival pathogenic bacteria could be useful to control periodontal infections in the population. You want to read on? You can read it yourself. I will read it with you. Without any involvements from dentists. Now, unfortunately, I can't see you. I can't look into your faces, and as specialists in periodontology, you should not feel really well right now anymore. And also for all the other colleagues, that means now only by using this type of therapy, metronidazole and amoxicillin, that is what the study is saying in the conclusion, we can avoid the treatment done by a dentist. I think this is far away from a real ethical approach towards the patient, because as we mentioned, or as I mentioned in the beginning, out of the statement of the American Academy for Periodontology, we said there is a plaque formation, there is a biofilm, there are bacteria which are not only within the pocket, in the periodontal pocket, but also migrating into the soft tissue part in the epithelium lining, and also on the hard tissue part, on the root surface. So I think to remove those subgingival concrements, to clean out the pocket, is one of the essential parts of our treatment to help our body to recover and also to initiate a real healing. So we have to question such kind of studies. Who might be behind such studies? I think pharmacy is pushing these kind of studies, but this would be all good if we would not face bigger side effects. I just want to be very honest to all of you around the world, even that I can't look into your faces as I mentioned before, but if you are a little bit more critical, reading newspapers, reading publications, what is going to happen within our societies, in our population, that we have more and more increasing resistance towards antibiotics, then we should understand that we should look really for an alternative. Look here, I just want to show you something which I think is very important out of the Journal of Antimicrobial Chemotherapy. And there it is written, methicillin-resistant Streptococcus aureus. And we know where Streptococcus aureus is found in our body, not only in our periodontal pocket or in the oral cavity, but in many other diseases. And as you can see here on the map of Europe, even including Turkey and Israel down there, you will find that in some of the Northern European countries, Scandinavian countries, we still have quite a healthy society, or let me say, less resistance against Streptococcus aureus. So the bodies are still strong also in their own immune system. Or antibiotics are working still very good there. But already when we are looking in the central part, in this orange area where Germany is located, Poland, Czech Republic, Belgium, and so on, there we have already a resistance up to 25%. And in the red parts, Great Britain, France, Spain, Italy, Greece, Turkey, Israel, we find resistance up to 50%. So trying to treat patients having a strong, high amount concentration of Staphylococcus aureus, we are facing a situation that up to 50% of the treated patients will not respond to the treatment because there is a high resistance against this type of therapy. Now, if you look at Enterococcus fecalis, now you see the picture is changing dramatically. Now also in the Scandinavian countries, we find, for example, in Norway a resistance up to 50%, and in Great Britain and Greece more than 50%, Germany up to 50%, Spain up to 50%. I think this should really wake us up and should generate in us the question, what alternative treatment or treatment methods do we have to avoid to give just in a routinely, in just a daily routine, antibiotics without reflecting what could happen in future when more and more resistance is generated out of a constant giving of antibiotics. Because, my dear friends and dentists, this type of microorganisms are not, as I mentioned before, found in the oral cavity, but in many other diseases in our body, and a medical doctor, a specialist in different parts of our human system, they will also use the same antibiotics we are describing for our patients, and this might be an overlapping in time, in quantity of doses, and will generate something which I will want to show you here in the next picture. You see this headline again published in the Journal of Antimicrobial Chemotherapy from David Livermore from the UK, from London, very famous institute. And the headline says, "The Zeitgeist of Resistance." Now, some of you might be astonished about the word Zeitgeist. Yes, it's not an English word. It's an English journal, it's an English author, but he's using a German word because this word is so specific to what is happening within a society that means a very severe change is taking place. And if you read a little bit about that, what he's writing in his article, I just want to read the first part, which is highlighted in yellow. The accumulation of bacterial antibiotic resistance is a dramatic demonstration of Darwin's dictatum of the survival of the fittest, with serious practical consequences for the treatment of infection. Now, we should stop just thinking about treating, because we are only treating the oral diseases. As I said, we are a part of a big number of doctors who are treating a person, a patient. And we have to think about what we are doing, and we should reflect what is going to happen if we are not really reflecting our treatment methods. Now, look at this table down left. You will find a dramatic increase. So look, in the year 1990, there was almost no resistance against any antibiotics. In the year 2005, we have already a very strong resistance. And you see, this is not a linear curve. That is a curve which is frightening us, because we can see year by year the increase of resistance is growing, and already today we are finding situations in hospitals that patients are treated and there was no reaction found, and patients are dying on very simple diseases, we could say simple diseases, which were treated 10, 15, 20 years ago, very successful with a certain type of antibiotic, and today it's not working anymore. So think about what you're doing and what could be done in future in order to avoid the over-treatment with antibiotics. Once more, please, my dear friends, not against the treatment of using antibiotics, only against to use unreflected. We should really think about what we are doing, when we are using them, under which conditions, and then we will be in the right way of treating them. So let's go back to the normal conventional treatment procedures. But for me it was important, I don't want just about the use of a laser and we say, okay, wonderful, a laser should be integrated in periodontal therapy and blah, blah, blah. Modern, it's good, it's nice. We should really think how to integrate a very nice technology, and what is really the reason why we are going to integrate such a technology, and in which way it could be helpful to us in order to be more successful over a longer period treating periodontal diseases. Now, conventional treatment, as I said, we are having three major targets. Elimination of etiological factors, of course, yes. Whether we are doing it with or without laser, this must be followed. Repair and regeneration of lost attachment, yes, for sure. Prevention to conserve treatment success, Of course, that means the recall system must be implemented and must be followed. So only then we will be able to get such kind of gums. We will have a very nice, healthy periodontal tissue. Now, when we are going on and we are taking in consideration what are the major steps in the periodontal conventional treatment procedures, then we will find, number one, scaling and root planning. Of course, as I mentioned already before, just to use antibiotics, remember the study out of the Journal of Clinical Periodontology, we can reduce the signs of inflammation, and it might look good, but we have not really removed all the reasons and the parts which are leading to this kind of disease. So scaling and root planning is very important to us, and we really want to follow them. On the second part, it says biological treatment. That means now, okay, if scaling and root planning, that is how we have been taught and how we are teaching our undergraduate students, and of course our postdoc students becoming specialists in periodontology. If scaling and root planning alone is not successful, then we should take in consideration to use an additional antibiotic therapy. And of course, if the disease already has reached a stadium where we have to say, okay, without a surgical procedure, we cannot treat the patient successful. Of course, then we have to do an open flap surgery. We have to clean out all the diseased root surface, the dental interradicular parts, the bone surface, and so on. That is all okay, what we want to see, but as I mentioned before, scaling and root planning, for sure. In cases where we have very, very strong and heavy destroyed parts of bones and so on, then of course surgical procedures as well. But now we have to question, can we do a treatment, scaling and root planning, plus laser, without using antibiotics in a routine in order to avoid that what I mentioned before, and still getting the same or maybe even better results in our treatment? That is what is really challenging us. That's what we want to see. So in order to see that, I think for those ones who are not so familiar with lasers, but also for those ones who are, we should take in consideration that we are not talking today about try and error studies and saying, okay, we are thinking it could be, we want to integrate a laser, and because some companies are mentioning, oh, that is very fine. So we have done very intensive evaluations of all the publications found in literature, and a team of specialists which I have invited to the University of Aachen from all around the world, from Japan, Professor Ishikawa, for example, a very well-known periodontologist, but also Professor Anton Skulian from the University of Bern, and so on, and other very famous colleagues in periodontology. We have been sitting together discussing all these issues and problems and evaluating the literature to see what could be done. Today I just want to summarize and focus some of that what was found. We have a selectivity about microorganisms. Already in the early 90s, first studies came up. Then hemostatic effect. We have vaporization of infected tissue, reduction of subgingival microflora in a very nice way from leading universities, Columbia University, Ohio State University, University of San Francisco, University of Tokyo, and so on. Many other universities around the world, and of course also in Germany and in Switzerland, in Austria. Then of course selective elimination of melanin-producing bacteria. Professor Marsh Miller from Bristol University in the UK was the first one to find that especially those bacteria who are pigmented would be highly absorbing this laser irradiation of near-infrared lasers and destroying them selectively without harming the surrounding tissue, which might be a very positive way to treat them. And on the other hand, we know that this near-infrared light is even stimulating the healing process within destroyed or inflamed or harmed tissue. Then, of course, delayed pocket recolonization and higher efficiency in the reduction of subgingival flora. Also, a very nice study. Subgingival laser scaling and root planing. That means the combination of conventional scaling and root planing plus laser, where we have done studies together with the University of San Francisco, Columbia University of New York, and Bristol and Aachen. And also the importance, what I want to underline is that we have done also monolayer cell culture studies in order to find the right settings, the right Hertz rate, the right energy density to really selectively remove infected tissue, destroy microorganisms without harming connective tissue, bone or root surfaces. That is very important, and that is why I can only underline even that people might think it's so easy just to use a laser going around the periodontal pocket. That's not the way. You have to get a real profound education to use lasers in a right way, and that's why I'm of the opinion if you don't know properly how to use a laser, better you don't use it. But if you know how to use it, you will be quite successful, and you will see how happy your patients will be due to this type of treatment. Then other clinical studies have been done. We have been even involved in the study for the FDA approval of near-infrared lasers, especially in the periodontal treatment. And as you can see here, out of this research, the black line is the control group, the red line is the scaling and root planing, and the green line is scaling root planing plus laser. You can see it's always highly significant better, or we get better results than only by using conventional methods. So also when the newer types of laser came into the market, such like diode lasers, you will see already starting the year 1997, diode lasers have been introduced to periodontal treatments. Today they are so widely spread because, of course, they are much smaller, much cheaper. They have a very good possibility to be absorbed very selectively because these types of laser are in the near-infrared spectrum of the electromagnetic spectrum, and that means all these pathogenic bacteria, 96% of them are pigmented, black, brown, red, brown, black, brown, will absorb this wavelength and for this reason will be destroyed. Also in earlier days, already erbium lasers have been used in order to clean root surface, to do an ablation of subgingival concrements, and also that was done quite successfully because no thermal damage has been seen towards the pulp or destruction of the root surface. Very nice removal was done, but of course, due to the type of application or the tips which have been used, not all areas have been reached easily, and that is why further studies have been undertaken. Now, there have been many publications in very well-known journals been published on this part, subgingival calculus removal, as you can see it here. And we can say, if you look at this comparative picture, left side scaling and root planing alone, right side erbium laser, you can see the cementum layer was quite well removed by scaling and root planing. But when using a laser, we can even save the cementum surface on the root surface, and we all know how important it is for a nice reattachment or a new attachment, depending on what type of treatment we have been undertaking or doing. Now, only a little clinical case out of the time when this was initiated. Already you can see the situation before, the probing, pockets with more than 6-7 millimeters, and then 6 months later, a very nice healing process. So This was the past, knowing that different types of wavelengths used could help to improve the treatment and to gain better clinical success. Now, lately, a new type of wavelengths came into the market, which is the 940 nanometer diode laser. And in a study of Professor Romanos from Rochester University in the US, published in 2014, it was very nicely shown that with these special wavelengths, because this wavelengths is specially absorbed in melanin and very high, best absorbed in hemoglobin. So that means with a low output power or a lower energy density, we still have a very high resorption and a very high efficiency. So the possibility to remove the thin pocket epithelium where we might find actinomyces groups, because they are migrating in there and which are normally only successfully treated by systemic antibiotics. So this can be done very nicely with this type of laser, and we see here with 2 watts in a continuous wave with a 300 micron fiber, energy density of 1.69 times 10 elevated 5 watts per square centimeter, means we have a very sensitive way to treat diseases integrating this type of wavelength. Of course, other studies have been done and published. There's also a study of 2014. There are much more. There are more than 150 studies published in very high-ranked journals. But of course, I don't have the time to discuss and show all of them to you. But also the clinical and biochemical effects of diode lasers as an adjunct, non-surgical treatment of chronic periodontitis could show the improvement of the treatment by just integrating this near-infrared diode laser wavelength. Or in this study here was very nice shown that of course the 940 has a very high inhibition towards microorganisms associated with gingivitis. So also the different types of gingivitis. That was again a study of the 940 nanometer diode laser, this EPIC 10 laser. Then, of course, another interesting part, and that should be very interesting to you, that also the mRNA expression of growth factors and type 1 collagen of human gingival fibroblasts have been highly stimulated. So you see, not only the bactericidal effect, but also the healing, the regeneration process is very positively stimulated or supported by using this type of lasers next to our conventional scaling and root planing. That means as an adjunct integration of this type of wavelength. Now, when looking at a laser system, such as an iPlus, we find 2 different wavelengths. Unfortunately, I have to say I'm a little bit unhappy that I can't get my arrow in the presentation in order to show you where what I wanted to say. I think I got it. Yeah, wonderful. Here, this part where the green arrow is, this is the erbium chromium YSGG handpiece. On the other hand, this part here, this is the diode laser 940. It's called the iLaser, or what is more important for us is that this is the 940 nanometer diode laser. So we have 2 different wavelengths in this technology, and we will later on find out what might make the difference or the support, or which kind of synergistic effect could be seen out of this treatment. So when looking into a comparative analysis of root surface smear layer removal, then we can see that especially now the erbium chromium YSGG part, so that's not the diode laser, that is the mid-infrared laser, was very nicely successfully used to remove the smear layer and also remaining subgingival concrements and creating a nice roughened, something like a retentive surface, so that a new attachment can take place much easier. And on the other side also we have a vaporization out of infected material. In another study, which we have also done here at our university, is to show also not only that we can remove the smear layer, not only that we can remove remaining subgingival concrements which have been left over after our mechanical therapy, but we can also see that with an erbium chromium YSGG laser, with a very specific radial firing tip, we have a very nice and high bactericidal effect. And just to see it out of the study, you can see on the left-hand side the different microorganisms which we have been investigating. And on the right-hand side, you can see the decrease of microorganisms. You see here, that's before, that is after, that is 3 months after, and that is now 6 months after. You see a continuous decrease of microorganisms, and in this way, we are facing a situation which we can say wonderful for all the treatment. We have also done a very nice clinical study where we showed the combination now out of both wavelengths, the 2780 erbium chromium and the 940. And also here it was shown that all pathologic signs of inflammation, the amount of bacteria, the healing effect was very, very positively stimulated. So we can conclude diode laser should be employed as an adjunct to conventional mechanical treatments, should be used to remove infected granulation tissue and epithelium lining, disinfection and detoxification. And on the other hand, additionally, in the follow-up, the low-level laser therapy with the same wavelength will be used as a biostimulating effect for a better and faster healing and the long-lasting. And on the other side, the erbium chromium laser, again as an adjunct, should be used to remove infected granulation tissue and epithelium lining, disinfection, detoxification, what we have been proving through the other studies, but on top of root surface and debridement of calcified deposits and contaminated cementum. So that is now where we can see that we will find a synergistic effect by using both wavelengths. As an overall conclusion, we can say when integrating these two wavelengths with this machine into our periodontal treatment concept, we can say diode laser for best bacterial reduction and biostimulation, and erbium chromium YSGG laser with a radial firing tip for removal of biofilm, very important, and remaining concrements, as well as removal of infected tissue such as epithelium layer and granulation tissue. So I think now we are on a point where we can say exactly that's what we have been thinking and looking for without using antibiotics. Integrating this technology in our conventional treatment concept would help us to achieve, I think, a very good treatment concept and treatment result, sorry. That means now, when taking this in consideration, we will see how this combination of wavelengths is working, because on the one hand side, we have here the part of the erbium chromium YSGG. On the other hand, the 940 nanometer diode laser is located here in the electromagnetic spectrum. So we have a very high absorption in melanin and hemoglobin. We have a good transmission through hydroxyapatite. That means also our diode laser has a good effect even on the infected part of the root surface. And on the other hand, we have a very good ablation of infected material also on the hard tissue side using the erbium chromium YSGG part. And that is once more demonstrated here. On the one hand side, the 940 here, which is lined down here, and the erbium in the blue line going down here. So when coming now to the treatment concept, I want to underline, yes, of course, we are we are following step by step the conventional guidelines of a conventional treatment of periodontal diseases. We are only integrating our laser wavelengths at a special point within our treatment. So of course we are looking for the attachment loss, the plaque index, the bleeding index, the mobility, the X-ray, the microbiological diagnosis, as I mentioned before. And that means in our first session, seeing the patient, for me it's very important, it should be important for you as well, we should look and do a very clear documentation, photo documentation, because patients are forgetting after a while how they have been looking like before. A very clear medical history, or as we say it in German, anamnesis, or in the Latin language, a very detailed medical history, not only of the oral diseases, but over the overall diseases, because that should lead us to think about using or not using antibiotics, or more being in the direction of using lasers. Then microbiological test, that means we can differentiate much better what kind of periodontal disease we are finding and giving a better prognosis. Plaque and bleeding, as I said, and of course giving instruction to oral hygiene. Then, when we are coming to our second session, we are looking again at the plaque and bleeding index, because I want to see how my patients are reacting. Are they really interested? Are they really cooperating with me? Because in periodontal diseases, we need the cooperation of our patients. That is not only working that we are doing the whole job. No, they have to work with us along. That means now, after checking and seeing whether they are supportive, they are cooperating, then we use the 940 for a first bacterial reduction, as you can see it in the right picture up here. Then we are removing all the concrements and removing the plaque and so on. Then we are using the laser with the 1 watt continuous wave, going through all 4 quadrants, all the infected pockets, in order to make sure that we can reduce as much as possible the bacteria emia, which is normally happening when we are treating the patient mechanically. Yeah, and that is how we are going in a 360 degree around the teeth and the infected pockets, having a very special tip of 300 micrometer. Yeah, and then of course the conventional tooth cleaning. We take the X-rays to differentiate what is happening on our bone side. Sorry, I have seen my time is running out. I'm trying to hurry up in order to complete my presentation to you. Scaling and root planning, supported deep scaling and root planning. As you see here again, in this big session, as let me say, the major treatment session, we are looking, of course, and trying to help the patient with the oral hygiene. But then again, because we have numbed or anesthetized or frozen the tissue, whatever vocabulary you are using, anesthetized it, then we use the diode laser with 1.5 watts up to 2 watts, as we have seen it in studies, for the bacterial reduction. Then we are going to do conventional deep scaling and root planning, whether we are doing it mechanically with our scalers, or we are doing it in the ultrasonic device I'm preferring to use. That's up to you. That makes, as many other studies have shown, if you use the instruments in the right way, no significant difference. And after we have done the conventional deep scaling and root planning, in the very same session, we are using now the second wavelength, the erbium chromium YSDG laser with the radial firing tip. I hope you will see right now the video, how it is working. Okay, no, we should have already, maybe we can go on to the ones who are, I need the other video, sorry. That is only initiating the fiber of the diode laser in order to go nicely around. But when we are going around that is still the step 1, with an initiated tip, we have a much better access to have an interaction with the tissue. Then, as I said, the mechanical treatment with hand instruments or ultrasonic scaling. When we are looking in the AAP statement, there is a very nice statement that the root debridement scaling root planning can be nicely supported by erbium lasers as well. And then, as I said, then we use the erbium chromium YSGG laser with a very specific setting. With this, as I mentioned to you before, the radial firing tip will have a very nice, can go very nicely around and will radiate the soft tissue as well as the hard tissue side, and will not affect the deeper parts of the pocket, so we will have no destruction of these parts down here, because only 10% of the energy is going in the vertical way, which will help us. And as you can see it here, we can go very nicely around the pockets. We, of course, including a strong water spray, which you would see in the next video, just as a demonstration. Is it running now? Okay, yeah, thank you. So just that you can see, when you're going into these periodontal pockets, even there, in this part here, this patient of mine, there were pocket depth in the distal part of this upper 6 molar, where we had pocket depth of up to 7 millimeters. You see I have a marker on, and you see the water stream, and we are really nicely cleaning out, and the material is coming out of the pocket, as you can see it, in a very nice way. So we have a very, very high and good support to clean out these parts next to the Diode laser, which was used before, and then the conventional treatment, and at the end, the support of our laser. So that means now, hopefully we can go on now. Good, thank you. So, and can we go on? Possible? Yeah, then we get already 7 days later, we have a very nice clinical result, and the healing speed and the efficiency is very high, so that we can say and postulate at the 4th session we are doing the post-operative inspection. If needed, if we still see some signs of inflammation, we are going once more in this periodontal pocket, which still shows these signs, with the Diode laser. Then we do a nice photo documentation, and at the end a nice microbiological test, in order to prove and show also to our patients that our treatment was successful, and giving them also a good stimulation for ongoing. Also, what I would like to mention in this concept, we should agree with our patients that at least we want to see them 4 times a year in our recall. And whenever we see them in the recall, we should be very clear that they should be investigated. And if there are some signs of inflammation, then again we use first the Diode. If that is more severe, of course we are combining it also with the erbium chromium YSGG laser in order to clean out the pockets, very successful in the same combination as seen before. Now I have got a sign that my time is over. I don't know the procedure now. Can I still go on, or is the time out?
You can go on. No problem.
Okay. So I just want to show you a few cases, and I have especially used some cases which have been done by one of my master students in order to show you that's not only what I was doing, but also colleagues who have been following this treatment protocol, how the initial situation was, how deep pockets have been. As you can see, it's 6, 10, 9 millimeters, and then 1.5 years later, already you can see a very strong reduction. Also the way how the bone is rebuilt in the state in 2011 and then 2014. Look how nice the improvement is. And this is only done combination of conventional treatment plus laser, or also in this case here, as you see, very deep pockets up to 12 millimeter, close done, I know normally, according to our treatment protocol, should be done with an open flap surgery, but we decided to do it in a closed way because we knew the good success. And you can see also already in the follow-up, in the 2-3, the canine 12 millimeter pockets, and the 2-6, 9 millimeter pockets, very deep pockets. Also the microbiological testing was there. Now see the situation, how the improvement went on, and you will see the overall regeneration of pocket depth, and how nice the bone growth was, as you can see it in this part here and here, and as you have seen it before in these situations here. Now, also in this case, I will click it quickly through. You see 6 millimeter. Originally it was from 10 millimeters, then 6 millimeters and 4 millimeters. Something happened to the presentation for those ones who are watching that. I'm sorry. This part here actually are the 10 millimeters. This is the 6 millimeter, and this is the 4 millimeter pocket. Due to this presentation, something happened in the uploading of my presentation. Only that you can see the very nice progress. Also in such a, let me say, almost lost case, there was a combination of endo, perio, and surgery treatment. And because the patient was insisting he don't want to have an extraction, and we could save the tooth. And as you can see it here in the initial situation and the situation 2 years later, completely embedded in the tooth, and no pockets anymore, very strongly seen and very fine. Also here, 14 millimeters active pocket going down here, and then seeing the situation before and the situation after, ending up with only 6 millimeter pockets. Here also 7 millimeter pocket depth, and at the end 4 millimeter pocket depth after 3 months only. Not only that we have a reduction of pocket depth, but we have also a stimulation of bone healing, which I think that is the most important part. Initial situation 5 millimeters, 5 weeks later, that means after the whole treatment period, you can see 3 millimeters left. So in a very nice way, no antibiotics have been used in this case, only laser, biostimulation, bactericidal effect, and also stimulation of bone regeneration. That is what we can say, and what we also will transfer in the next step to the peri-implantitis treatment, which is only at the end a little candy for you, because we have almost the same reasons what we have for periodontal diseases, also in implantology, similar microorganisms. And as you can see here, the morphometric analysis of implant surfaces with a biofilm left after 24 hours, ultrasonic systems can remove a bit, plastic curettes and chlorhexidine another little bit. On the right hand side down, you can see with the laser you can remove all this biofilm in a very sufficient, nice way. And that is what we are also doing here in our department of periodontology. I'm treating also peri-implantitis cases. We are very successful in that. And also with this, we are mainly using the erbium chromium YSDG with the radial firing tip. We are going all around the periodontal pocket, cleaning out these pockets and having a very nice success on that. So we can avoid major flap surgeries, we stimulate the bone healing, we clean out the implant surface, and so we can also stimulate the re-osseointegration of the systems. Of course, in severe cases, we are doing also flap surgery and then cleaning out the implant surfaces with a laser. In this case, it was not needed because the pockets were not really deep and not too much bone loss was seen. But of course, we can we go to the next picture, please? Okay, so as a summary, we can say in this treatment concept, of course, I cannot go in all the details in such a short time. I even transgressed the time. I'm very sorry for that, but the advantages by integrating these two wavelengths in our periodontal treatment concept is very clear. We have a high bactericidal and detoxification effect, number one. We have a hemostatic effect, which is also important. We have a better access to anatomic difficult areas because with these fibers and the radial firing tip we can go in also in all the places which normally can't be easy treated with other kind of instruments. It's quite easy of use if you have learned and studied in a well way. It's a comfortable treatment for the patient, yeah. And of course, what I want to underline and I want to draw your attention back to that, what I said to you in the beginning, less or no antimicrobial therapy will be needed. So it doesn't mean if there are legal requirements or ethical requirements to use antibiotics, of course use them. But in cases that you can treat the patient with a laser using these two wavelengths, you can reduce all the microorganisms, you can stimulate the body, and overall you will stimulate his immune system for an overall better health of our patient. And last but not least, as I said, biostimulation and biomodulation. To use a laser, I think you should go for a good education. It has not to be a Master of Science, that is our top education, but at least a mastership should be there, that you really know how to use these two wavelengths. But if you want, you can receive here a full Master of Science academic degree at our university in Aachen. And with this picture, I would like to say thank you very much for your kind attention. It was nice talking to you around the world, even though I haven't seen you. This is very strange to me. It's the first time for me to talk in this way to some of my visitors, but happy to have done that and wishing you a good success. Hopefully see you once face to face. Thank you very much. Bye-bye.